Thank you, Niall. Okay, so how will we do transformational work in this field? I won't say in case it's disturbing for anybody, in a couple of slides I will mention briefly statistics on suicide. I just want to warn anybody who doesn't want to hear about that. So for my entire career, which started here at MIT as a graduate student, I've been impressed by the fragile power of the human brain. It endows us with all our capacities of thought, emotion, motivation, action, and perception. And for every strength, it has an Achilles heel. So, if you can have thoughts, you can have thought disorders and psychosis. If you can have feelings, you can have anxiety or depression. If you have motivations, you're going to have addictions hijack the motivational system. So for every human talent that springs from this material, a few pounds of tissue, there's risk, and we know now there's a lot of risk. I can't be humble enough about my role in this field. I'm not a psychiatrist. I'm not a clinical psychologist. This audience is full of experts who have actually helped people. I have not. The contribution I can make is from brain imaging. And so we have worked on in this building, in the beautiful imaging center we have, with children, adults, and adolescents on a number of psychiatric diagnoses. And one of the joys of working at MIT is that we are in the center of an unbelievable wealth of amazing biomedical research. MGH right across the river, McLean Hospital, Boston University. We have so many outstanding clinical collaborators who we learn from and work with, because we want to do the work that makes a difference. And it's always working with clinicians, talking with clinicians who work with patients, that we learn what difference can neuroscience make to help people. So this is, these glum statistics you can see every day on the internet or in the news of rising rates of suicide in adolescents and young adults. Both men and women for many years. Here's this rise of teenagers at 35% over the last 20 years. I mean, just terrible. And here's another statistic that's left out, because of course patients need to be helped, but families who care for them and love them are also drawn into these difficulties. These are the 100% increase of parents driving their children into emergency rooms because of suicidal ideation or suicidal attempts that are so scary the parent feels the only choice is to drive that child to the emergency room. But we know these are very glum statistics, and that's where we are. While we're trying to make progress, mental health is declining over the last decade. We're not making progress. We're actually losing ground from where we were. And I'm using some bold language today, that to a surprising extent, our efforts have been ineffective in changing that tide. In some corners, yes, but not on scale. And I remember I was serving on an advisory panel for NIMH, National Institute of Mental Health, when Tom Insel was in charge, and the optimism in the 1990s about how close we were to making amazing progress was huge. We had this revolution in neuroimaging, the brain basis of psychiatric disorders, this revolution of the Human Genome Project, right? And I think everybody thought that amazing progress was around the corner with these scientific tools. That was 25, 30 years ago that amazing progress has not occurred. So we need to think. That's why we're having this session today. It's not only meant to be about presentations, but really talking and thinking together about what could make a difference. So here's an example. And again, I work in the field of neuroimaging, so I'm throwing myself under the bus, as they say, of publications in PubMed just searching by MRI and major diagnoses. So ballpark 50,000 studies with MRI, never mind PET, MEG, EEG, right? 50,000 100,000, and yet a couple of those I'm involved with. Yet, how have we improved people's lives, and what would it look like for those studies to turn into that? It's a question I ask myself, because our goal is not simply to produce another result in a publication, but to make a difference. And it's shocking, again, how all the movement in brain imaging, all the movement in genetics, this cartoon is the expansion of DSM categories. You could think it's kind of funny that we have more and more diagnostic labels, or you could say maybe we're just more and more sensitive to variation in mental health. But, we just, and I feel bad throwing my genetics colleagues under the bus with me, but, we're all in that place. Okay. So, in my perhaps wrong and highly opinionated perspective, I can think of 3 areas where I believe research could make a significant difference in a reasonable timeline. And again, this is very editorial, and this audience is full, online and in person, of more expertise than I am in many ways, but here's what I think. So one is early identification and prevention. We wait too long, I believe, for things to move downhill into tragedy before we spring into action. We wait until somebody's so depressed their parents driving them into the hospital. Can we do something to identify earlier who's high risk, who's moving towards high risk, and see if we can help them? So I'm going to show you one small study we did in that regard. It's a small study. It's a proof of concept, if you will, of a pilot study, where we looked at individuals who were children in families with a parent with a history of depression, or children who came from families without such a history. And none of the participants in the study, none of the children had any had depression at all, or even subclinical depression. A few had some symptoms, but many people have some symptoms above 0. And so what we did is compared brain responses to this. We showed them pictures of facial expressions, including very negative ones or very positive ones, and compared responses in the brain. And here's one thing we found in these children with families with a history of depression or without. We compared those, and what we found was this. On the top, you see more activation in the children without a family history to positive faces. Okay, and more activation for children who came from a family with a history of depression to negative faces. This is exactly what you don't want in somebody: an under-response to positive things and an over-response to negative things, right? Because that's a view of the world that's hard, that amplifies the negative and sort of discards the positive. So already in these children, without any symptoms, and with the family history is evident, and we also found that if we wanted to compare the children with and without a family history, that we with a CBCL, a standardized checklist that the parents fill out about the children, brain imaging evidence was more separating the children with family history from those without than a conventional clinical measure. So that won't always happen necessarily, but it's a hint that maybe the brain adds information above and beyond already standard clinical information. And then we follow those children for, again, now it becomes a vanishingly small number, but still 40% of the children who came from families with a history of depression developed clinical depression about 5 years later. All right, so that's a high rate of conversion, but it's what we know, it's in the ballpark of what's known. And we asked, if we looked at the brain imaging 5 years earlier or so, could we get a correlation with which children with a family history did or did not develop depression? And we got both correlations that went with children who did develop depression, as well as some other correlations in brain response for children who didn't. So we think we identified in a small sample, we need larger evidence for this, some neural correlates of risk that leads to conversion to depression, and of resilience that allows some children to not move into depression. And if we compared the difference between clinical measures and brain measures in predicting who would convert. In this study, the brain measures outperformed clinical scales that are given to parents about their children. So a small study, there's a few other ones a little bit like it, but it's possible there are signals, behavioral and in the brain, of children who are on a path towards something like clinical depression. Why can't we possibly try something before they have to get diagnosed and to all the difficulty they face? You wouldn't probably think about giving them a medicine, maybe, because they don't have it, but behavioral treatments are benign. And imagine you steered or navigated and helped these children avoid ever becoming clinical depressed. I mean, it seems to me so important to do, not to wait for all the injury that occurs with a developing psychiatric disorder in childhood and adolescence, but to go in and prevent that from happening altogether. Okay, so so I realized with this setup, I barely see my slides from this angle. Okay, so okay, thank you very much. I should have asked. Okay, thank you so much. So another study that we published a little bit back was colleagues at Mass General Hospital. We know that bipolar disorder is often misdiagnosed as depression in children because part of the presentation of bipolar includes phases of depression. And that has severe negative consequences because pharmaceutical treatments that are appropriate for depression are often counterproductive in a medically severe way for children with bipolar disorder. So this is amazing. This is a really interesting data set with 490 children, ages 6 to 18, who were seen at baseline and 10 years later. They were assessed with psychometric scales and structured diagnostic interviews and multiple measures of cognitive and social abilities. 45 children, 10%, developed bipolar disorder 10 years later. And working with my colleagues here at MIT and MGH, we used a machine learning program called Balanced Random Forest Algorithm. We had to use one that would work for low rates of incidence, right? Because if you just predicted who would not get bipolar, you'd be 95% correct, right? Because that's okay. So we had to have something that would pick up the cases of this small number. But that machine learning thing identified correctly about 3/4 of the children who 10 years later would develop bipolar disorder. So we know that in addition to brain imaging, artificial intelligence and digital methods and AI will be another thing that we can do. But how far are we perhaps with these measures? These are not brain measures, these are behavioral scales parents fill up. How far are we from maybe having a risk calculator that could sit on the computer in a doctor's office, a pediatrician or child and adolescent psychiatrist, and maybe they could say, wow, this kid has a higher risk, I should pay extra attention if they don't have the more common diagnosis of depression and the less common diagnosis of bipolar disorder. So, again, we need larger samples, although this is a pretty good size sample. Okay, precision or personalized medicine, the hope that if we know more in some way about a patient, we can better predict what treatment will be effective for that patient. And I like these quotes about prediction. Prediction is very difficult, especially about the future. On the internet, there's debates about whether that's Niels Bohr, Robert Peterson, or Mark Twain. Okay, it doesn't seem to be settlable who came up with that. I like this Kierkegaard's one: life can only be understood backwards, but it must be lived forward. So difficulties of prediction. And one of the iconic studies in the field in terms of the necessity to get better at this is a STAR-D study led by Maurizio Fava at MGH, the largest study of drug treatment of depression for 1,000 patients. And what they found was that the first drug that was given, only about 35% of patients really benefited. Then they got a second different drug, another 25%, a third different drug, about 20%, a fourth drug. By the time patients went through 4 drugs, 70% had responded. That's still 30%. That's a lot of patients who never responded. But the other thing that was really telling about this, is that even though the patients were promised subsequent drugs, come back to the study. We'll give you a second one, a third one, a fourth one. Many withdrew after each round because the treatment failure was so discouraging. So treatment failure has so many consequences besides the initial failure to help, discouragement, and so on. And to this day, we don't have the field does not have, I believe, and please correct me, amazing psychiatrists and all of this, a really a scientific way to know which treatment to give which person. So let me tell you about one prediction study we were involved with social anxiety disorder, unreasonable fear of social situations, a fairly common disorder. It impairs, at the clinical level, it impairs quality of life. I was impressed that it has twice the rate of unemployment versus other anxiety disorders and depression. Because probably, if you're so uncomfortable working with people, interviewing for jobs and so on, anxious situations like that, that makes seeking employment and retaining it extra hard. Okay, so the common treatments are behavioral treatment or pharmacology. Again, 30–40% of people are helped substantially by any particular treatment. Again, no scientific evidence to choose one form of treatment or another. And so we did a study with Stephen Hoffman and other people at Boston University, 51 patients before and after they received CBT, behavioral treatment. And we asked whether brain measures before treatment would be predictive of who responded and who did not. And we used a widely used scale, a Liebowitz social anxiety scale, as a measure of improvement. And what patients did when they came into MIT for brain imaging was they saw pictures either of negative and positive scenes or emotional versus neutral faces. And when we got our brain differences for the faces, seeing the negative face was provocative for the people with social anxiety. And we got, in this study, a pretty strong correlation that the more your brain responded to these negative facial expressions, actually, the more likely you were to have clinical benefit from the behavioral therapy. So this is, that's the statistics. This is a simple picture of if you divided the people in half of those who had better outcomes, for whom CBT was beneficial, and those who did not. So we also looked at connectomics, diffusion imaging to look at white matter connectivity anatomically and functional connectivity in the brain. We seeded the amygdala, an area that's often involved in perception of negative facial expressions, and looked at what it's connected to. We also did whole brain multivoxel pattern analysis. I won't go into detail just to tell you we did these things. We also looked at white matter, and what stood out was the right inferior longitudinal fasciculus, and some relationship between that white matter before treatment and treatment response. But here's, I think, the really interesting things in my thinking. So how well did the initial clinical severity, the initial clinical scale, relate to treatment outcome? Modestly. Okay, and by the way, that's what you typically see, a very, very modest relations between clinical scales and outcomes. And by the way, with a larger sample, we applied machine learning. We thought, oh, if we have machine learning and AI, that's going to go way up. It doesn't go way up, okay, on a larger sample. It stays in that same ballpark. That doesn't mean that people won't invent a new scale next week or next month. I mean, we're not done in improving how we measure things. But for currently used scales, this is where we are. Now we add in the measure of white matter connectivity, and it moves up. Now we add in the functional connectivity measures, the functional MRI, and then we put them all together, and now we get something that's potentially useful. It's not certain, but now we're talking about an amount of variance that might be suggestive to a patient and to a clinician about whether CBT would be effective on behalf of this patient. So there's a couple other studies on depression that have similar kinds of findings from Stanford. I think there's a lot of promise in this, where we are at the moment, although far from conclusive evidence. Okay. And then we also looked at, how much of the variance is accounted, again, it's a different way of saying the same thing, by the clinical scale, and by the imaging, and we get to much better predictions of who will respond with the brain measures. Now, as researchers, we like continuous scales, but people often like green light, red light. And in fairness, that's the decision that clinicians and patients face. You can't tell somebody, it's a 58% chance this will get better. What should we do? They either get the treatment or they don't, either by the clinician or by the patient. So we do have to think somewhat in terms of categorical things, I believe, if we're to move these kinds of measures into clinically salient decision making. So we picked a line with consulting our clinical colleagues of what would be considered to be like a good improvement versus not enough, and combining the brain imaging as well as the initial clinical scale. In this study, we came out with a pretty good prediction, about 81% accuracy, of who would be in the group who improved a lot and who would not. So it's hopeful as a direction of matching up patients with more likely treatment success. So again, I look around this audience and I see people who know so much more than I do about this, but here we go, amateur hour. We know that on average, diagnosis was poorly predictive of response to treatment, right? We just know that. And we also know that many patients have multiple diagnoses as part of the complexity of psychiatry. We also know that many, and there's been now very convincing large studies, that many of the brain, genetic, and cognitive and emotional differences are transdiagnostic. If you look at large samples with many diagnoses, many things in the brain and in the mind cut across those. In 2010, NIMH came out with a plan that seems to me still scientifically sound. They said because these diagnostic categories are so problematic, let's have areas, let's do it by content, things like arousal regulation, positive and negative valence, sensory motor processes. Let's look at psychological categories that we map regularly onto the brain by imaging, by animal research, and so on, instead of the diagnostic categories. That was 2010. Very good idea then, I believe. It's hard to say that the statistics have all gone bad since then. We haven't. I don't think, I'll be editorial now, that's helped us all that much. Other people might feel completely differently, and it'll be free to tell you, but it just hasn't moved the needle that much. It was reasonable. And another thing that's really hard is that although some areas, I think, have really benefited from large open data sets, publicly available large data sets that have been very helpful in many areas, we lack those for treatment. There's very few places you can go to for a large-scale, rich data set for treatment, because that hasn't been something that's happened. I'm looking at someone, the psychiatrist here, and going, are you okay with that? Okay. We're not okay with that, actually, but that's where we are. Okay. So here's where I mean to be provocative, but seriously so. I think at the moment, the only thing that matters in psychiatry is effective treatment. I'm sorry, okay, I'm sorry. At MIT, we want to understand how the cosmos happens, the beginnings of life. Those are good scientific questions. For psychiatry, we do want to understand basic things. But the only thing that matters in the end is who gets helped, right? And so, I feel like at this moment that if we have valuable progress in the field, it must involve treatment as part of that process. We don't need another 50,000 MRI publications and so on at the moment that are not really hooked into treatment outcome in some way. And some of it, we'll make mistakes, we'll stumble along, but at least we're in the right place, right? And more basic approaches, and I've been involved in the imaging end of that, have just not proven themselves to make a difference in the everyday life of lived experiences of patients and their families. So I'm kind of surprised we haven't had more, and maybe I've missed some of this, strong studies of early identification and early intervention. There are very, very few studies out there, I believe, on this at all. That would be the best. Steer children away from depression and anxiety or other things early on. So we don't know if that will work, but how can we not be trying that given the evidence we can have about who's at high risk and who's not in multiple ways? How about personalized or precision medicine? If we combine the best of what we have of clinical characterization, imaging, genetics, digital and AI tools, maybe we could do something pretty impressive. I'm looking at Jordan Swallow, who wrote on the internet, the $500,000 budget. I know funders will always say, like, all scientists do is say if they have more money, they solve everything. But I think more money would help in the following very concrete way. To do clinical treatment plus imaging plus genetics plus maybe something digital, it's a fair bit of money per patient. It just is, I mean, in the most practical way. It exceeds 500,000 even in a very modest number of patients. And I know this from writing grants on this exact. And Jordan has pointed out that 500,000, when that became the NIH limit, is something like 250 now. It hasn't been adjusted for inflation. And so, I respect the idea was that is to have spread grants around among many investigators, but I don't think that can be accomplished seriously for treatment studies on any scale with all the tools we now have, and to see whether we have the tools in place now that would help us know what treatment to give which patient. It's possible we have them if we had a strong enough study. How big does the study need to be? This is a really interesting question, because obviously we don't want to be tiny. That's not good. At the same time, a really big issue is the effect size of any of these things. So we always publish, I do too, P less than 0.05 with a 2% difference, we're happy. But we know that small effects will not be informative for individual patients. So if we have I don't think we need very large samples to work on this. We need to worry about who's represented in the sample, for sure. But I don't think we need, the large samples that some people now talk about to solve problems of replicability. So these things have to work for individual patients in relatively modest samples. The sample size, I think, need not be large. The effect size has to be the individual patient, so they make the choice with their clinician of what to do. And then the other thing, and so I don't think the studies have to be huge in number, but they have to be rich in science to see if all the science we have now can make a difference. Lastly, novel treatments are so exciting, and you'll hear throughout today some of the most exciting advances in new pharmaceutical treatments, the use of digital tools and AI, individualized brain network therapeutics, because in addition to the treatments we now have available, we just need a bigger and richer arsenal of treatments that might help people. Now let's talk about the complexity of I think what we face, honestly, is that understanding mental health almost requires us to understand the unbelievable diversity of humans. Okay, right? And it's not like we understand that very well. Okay, so we just have to use all the tools we have now and develop new treatments that will work for people for whom all current conventional treatments don't. So this is my last slide, and I'll just say, I think of infants around the planet as being born with genetic predispositions and into environments or experiences that will be more or less supportive or risky or adverse. And, it would be awesome, right, if amongst all of us, a large community of scientists and funding partners and others who all work, government agencies who work together, if we could have so many more children grow up safely, happily, compared to where we are right now. So we do need this. We do need the moral equivalent of a Manhattan Project to make a difference soon, as we can imagine doing that. So thank you very much for your attention.